Hi, I'm Jessica,
And I'm Caitlin.
I'm Francesca.
and we're going to be discussing the assessments we've discussed in evaluation of occupational performance. We'll be discussing the evaluation process, occupational performance, motor, sensory, cognitive, and vision. In the evaluation process, we have the occupational profile where you will gather information about your client. They'll have their self-description, which will include personal information about themselves, the daily activities they enjoy, the roles they deem important, and the importance of each. Some helpful tools for such an occupational profile would be the COPM. In the analysis of the occupational performance, that's what you'll do after their occupational profile, you'll start to plan your next steps. You'll need to use clinical reasoning, two of which would be scientific and procedural. You'll need to decide what evaluation is needed. So you want to focus on the occupation-based evaluation strategies, and then also plan which assessments you'll use. In the assessment and evaluation, there are methods you can use, such as interview and activity-specific assessments. You can interpret and identify their facilitators and barriers to performance. You need to know how to restore functional abilities, modifications to improve occupational performance, and effective interventions consider their needs, experience, interests, and priorities.
In learning how to evaluate occupational performance, we focused on 6 different areas: roles, ADLs, IADLs, leisure, social participation, and work. We studied many assessments in class, and as we encountered future assessments, they will be easy to add to the concept map since it is organized according to occupational therapy domains following the OTPF. For each assessment covered, we decided to highlight the population, the purpose, the scoring, the reliability, and the validity. In learning how to evaluate roles, we practiced using the role checklist in class. So here you can see those important details. In evaluating ADLs, we learned about multiple assessments, but we chose to focus on the FIN, the Functional Independence Measure, especially since we learned so much about it in Dr. Ryden's occupational participation class and saw it used extensively in the hospitals we visited for field work. To evaluate IADLs, we practiced especially with the Executive Function Performance Test to assess client executive function, identify their functional capacity, and identify the level of assistance they needed to complete the tasks using a standardized queuing system. We also practiced the Coleman evaluation of living skills in lab to evaluate a client's ability to live independently at home and within the community. From the leisure assessments available, we practiced activity card sort in lab to evaluate changes in leisure activity associated with changes in health status.
All right, some motor assessments that we learned in Chan's first semester is passive and active range of motion, manual muscle testing to assess muscle strength, and this semester we got into assessing hand strength through dynamometer and pinch gauge. And for specific Klein factor assessments to measure dexterity and fine motor control are the box and blocks, Grude pegboard, Jepson-Taylor, 9-hole peg, and Purdue pegboard test. To assess muscle tone, we went over the modified Ashworth scale. We learned in Lohman's lab how to assess postural control and balance. And in Vroman, they talk about specific assessments or specific areas on the body to assess motor reflexes and deep tendon reflexes. All right, moving on to sensory. To assess tactile sensation, which are known as protective sensations, we can measure pain and temperature. We learned how to do each of these in Lohman's lab with a sharp dull to assess pain and with the thermal tubes to assess temperature. We also learned how to use an assessment, Sims Weinstein filaments, in Chan's lab, how to assess touch and light touch and different types of touch pressure. We also learned how to use different tools to assess tactile localization, 2-point discrimination with a discriminator, or a sthesiometer. We also learned how to assess stereognosis, proprioception, kinesthesia, and we learned about ways to monitor endurance, measure edema. Some ways that you can measure edema is the figure of 8 technique with the measuring tape or with the volumeometer. Some other assessments that we did not go over in lab but that are mentioned in Vroman are the Moberg Pickup Test, the Brief Pain Inventory Scale, short form, the McGill Pain Questionnaire, Numeric Pain Rating Scale, the Visual Analog Scale, the Wong-Baker Faces Pain Rating Scale, and the Borg Rate of Perceived Exertion. In learning about sensation, we were also encouraged to study the dermatomes and myotomes and innervations throughout the body to recognize where the patient may have an impairment. So here's some helpful charts. Okay, now moving on to cognition. Some sections that I'll be talking about are mental functions, cognitive screening, arousal, and of course other assessments. Mental functions, there's 2 that exist, specific and global. And this is a nice chart of the hierarchy of cognitive reasoning. Some cognitive screening tools that we learned about were the MoCA and the LOTCA. The MoCA is a rapid assessment that measures cognitive impairment in both medical and psychiatric settings. You usually use this with adults with mild cognitive dysfunction. And below, as you can see, there are the psychometric properties and the way you would score. LOTCA has 2 different versions, or a few actually, and there's one for geriatric population, a dynamic version, but the one that I'll be talking about is the LOTCA 2, and it screens basic cognitive abilities in order to discern cognition in the following areas: orientation, visual perception, spatial perception, motor praxis, visual motor, organization, and thinking operations. And it is for adults with acquired brain injury, spinal cord injury, and degenerative and psychiatric diseases. The scoring depends on the subtest that you use, but the total score is not recorded. Higher scores indicate higher cognitive performance within the subtest, and the psychometric properties are as seen below. For arousal, we learned about 2 different assessments. Rancho, it's based on 10 levels of cognitive function, behavioral characteristics, and reliance on assistance to carry out cognitive and physical functions. And then you can use this with children or adults who have acquired or traumatic brain injury. The scoring is based, like I said, on 10 different levels, and they all vary based on their description, and below are the psychometric properties. The Glasgow Coma Scale is an objective neurological scale that provides a reliable record of the person's level of consciousness, and it is based on 3 response scales of eye, motor, and verbal, and it is mostly used to monitor the neurological status of a patient that is comatose or to assess their cognition. The scoring is assessed against the scale criteria and allocated patients. And as you can see, here are the psychometric properties for the Glasgow Coma Scale. Some other assessments that I did not mention are all of these below, and they're all in Vroman. And now we're going to move on to vision.
In assessing vision, you want to create an occupational profile. You'll ask such questions as, do you wear glasses, contact lenses, and for what reason? Any previous eye injuries? Any previous procedures done to eyes? How often do you get your vision checked? Any current conditions? Do you feel you see well now? We have a visual perception hierarchy, and from the bottom to the top, you need the bottom to exist in order for the top to function correctly. And you have, from bottom to top, you have visual fields, attention, scanning, pattern recognition, visual memory, visual cognition, and adaptation through vision. Visual acuity, it's the ability of both eyes to focus clearly on objects that are close or at a distance. And you're very familiar with the Snellen chart, which you see in a lot of ophthalmology and optometry offices. And your normal vision is 20/20. And then visual fields, it's the ability to attend to focus stimuli and to the peripheral environment around it. Your normal vision field for superior is 60 degrees, nasal it's 60 degrees, inferior it's 75 degrees, temporal it's 100 degrees. And then essential questions you want to ask is, can this impairment be remediated? If not, what compensatory strategies and/or environmental modifications can be used? Visual perception and cognitive skills do overlap, such as a person driving in a snowstorm, or for example, all of our vision fields are intact, but we do perceive colors differently, which is cognitive. And then again, we have the hierarchy table mentioned previously. It is a bottom-up approach. And then we have ocular motor control. It's the eye's ability to coordinate with each other and move smoothly. We have the cortical and subcortical. And then functions we have are accommodation, binocular vision, convergence, saccades, and visual tracking and pursuits. And then we have the assessments listed here. They're very basic assessments. They can be done very quickly. And we have listed here for convergence, saccades, and tracking. And then regarding ocular motor disorders, they are deficits. They are slower and uncoordinated eye movements. You have headaches and you can have fatigue. And common disorders that you might see are diplopia, nystagmus, strabismus.
So as we progress through our MOT program, as we learn about more assessments, we'll be able to expand our e-portfolio under these categories or add more as they are exposed to us. Thank you so much for watching.